As physiotherapists, we work with patients who suffer from upper neck pain and discomfort. If we could better understand the structures that are pain sensitive and the way in which the nociceptive information is transmitted to the central nervous system, we could provide our patients with quite better healthcare. On that note, I, Dr. Zubin Bhavsar, would forward you this presentation. If you have not attended our previous presentation on cervical spine anatomy, do go through the website www.physiosports.in for more details. The topics for presentation: aims and goals, what we want to accomplish, general introduction to cervical spine neuroanatomy, that is the innervation of the craniocervical region, and important notes, which are the key points and summary. Aims and goals. The aim of this presentation is to make complex neuroanatomy of cervical spine simple and easy to understand. To know the anatomical relationship between various neural structures and cervical vertebrae. Also to identify and know the pain generators in the cranial and to implement this knowledge in clinical diagnosis and treatment for cervical spine disorders. Contents of the presentation includes general introduction, relationship of neuraxis and cervical spine, neural innervation, that is the pain generators and the pain patterns of the craniocervical region, nerves of the cervical region, neuroanatomy of the cervical intervertebral foramen, summary, and key points. Migraine has estimated global prevalence of 14.7%. That's around 1 in 7 people. Approximately 47% of global population suffers from a headache, and 15 to 20% of those headaches are cervicogenic in nature or in origin. Estimated proportion of time spent with migraine and cervicogenic headaches, that is actually experiencing an attack during an average person's life, is 5.3%. Various studies have concluded that migraine is a disorder that almost certainly has genetic basis in origin. However, the pain conduction pathway that remains similar to that of craniocervical. General introduction. The cervical and craniocervical region houses one of the most densely innervated tissue structures. Various studies performed on symptomatic as well as asymptomatic subjects have collectively demonstrated that irritation or dysfunction of any structures innervated by 3 upper cervical nerves can potentially generate local pain or refer pain to head, neck, occipital and suboccipital region. Let's study what are the pain generators and pain patterns of the craniocervical region. We will then discuss how the knowledge of these different patterns of pain referral can assist in differential diagnosis of head, neck pain. In order to be classify the types of pain experienced by the patient, knowledge of craniocervical innervation, pain referral patterns, and upper cervical peripheral nerve pathways is essential. Craniocervical pain can be classified into peripheral nociceptive pain, local pain due to irritation of nociceptors, local somatic tissue of the craniocervical region, into refer pain of somatic structures within the craniocervical spine, also into peripheral neurogenic pain. Peripheral neurogenic pain can be a referred pain from irritation of the craniocervical neural tissues, which include upper cervical spine nerve roots, trunks. Now, before we dive deep to fish the pain, let's first understand about the orientation of nervous system in cervical. On your left hand side of your screen, in the X-ray image, please kindly note that black spiral-like shadow that is of the cervical cord inside the vertebral foramen. In the upcoming slides, we will understand the orientation of nervous system in the cervical vertebral column. We will obtain answers to how the nervous system is held in the cervical vertebral column. Also, what holds the suspended spinal cord in the cervical spine vertebral column. It is crucial for us to understand the spinal meninges. The spinal cord has its first meningeal layer, which is pia mater, which is the innermost laminating layer enveloping the entire spinal cord. The third outermost meningeal layer is dura mater, which is in continuation with the spinal nerve. In between the pia mater and the dura mater are the arachnoid mater, which are connective tissues in form of spiral web formation. Now, the denticulate ligaments, which are triangular in shape, attach the outermost dura mater with the innermost pia mater. The denticulate ligaments acts as an anchor point for the spinal cord inside the dura mater sleeve. Denticulate ligaments also separate the dorsal and the ventral rootlets. Now, the space between the dura mater and the bony ring of the vertebral foramen is known as epidural space. The space is filled with adipose tissues and blood vessels. Please note that the entire spinal cord is freely suspended in sac-like structure. The pia mater is attached with the dura mater by denticulate ligaments. The outermost dura mater or the spinal dural sheet is not glued directly with the vertebral bone, but instead the adipose tissues buffer the space, providing cushion against the hard bony parts surrounding the entire inside the vertebral foramen. The upper cervical spinal cord is directly attached to the circumference of the foramen magnum, to the second and third cervical vertebra, and by fibrous slips to the posterior longitudinal ligament. Please note the three meningeal layers, the pia mater, arachnoid mater, and the dura mater. The myodural bridges. The myodural bridges helps in anchoring the spinal cord within the vertebral foramen. This arrangement and their detailed function is discussed in separate presentation. This figure demonstrates the relationship between the spinal dura mater and the suboccipital muscles by the connective tissue known as the myodural bridges. The rectus capitis posterior major muscle, the rectus capitis posterior minor muscle. This is the spinal cord. It has the outer connective tissue layer, the dural sheath. The attachments between the rectus capitis posterior major and rectus capitis posterior minor are denoted by small a and small b alphabets, whereas the star over here defines the attachment site of the connective tissue, the myodural bridges, with that of the spinal dura mater. These are the key points. The suboccipital muscles are attached with spinal dura and they exert the tensional pull on the cervical spinal cord. Spasms of suboccipital muscles create tensional pulls in the spinal dura mater, limiting the mobility of the spinal cord. Myotomes also anchor the spinal cord, providing grip in the vertebral canal. We will now discuss about the neural elements. We will obtain answers of the following questions. What are the neural elements in cervical region and how are the spinal nerves formed? Cervical spine neural elements includes rootlets, roots, dorsal and ventral, dorsal root ganglion, mixed spinal nerve, ramuses, dorsal and ventral ramuses, cervical rootlets. As you can see, this is the dissected section of the spinal cord viewed from the dorsal aspect, and we can identify the dorsal rootlets separated by denticulate ligaments. Ventral rootlets are not visible as they lie on the ventral side. We now move on to the anatomy of the mixed spinal nerve. As shown in the figure, the dorsal and ventral rootlets of the cervical region leave the spinal cord and unite into dorsal and ventral roots. Dorsal and ventral roots unite within the region of IVF to form mixed spinal nerve. A mixed spinal nerve is short and almost immediately divides into dorsal and ventral ramus. The dorsal ramus is posterior primary division and ventral ramus is anterior primary division. Relationship of the spinal nerve with cervical vertebra. Superior view of a typical cervical vertebra showing the relationship of neural elements. Notice the dorsal and ventral roots, the mixed spinal nerve, and posterior and anterior primary divisions, which are dorsal and ventral rami. The posterior primary division can be seen dividing into medial and lateral branches. The recurrent pharyngeal nerve is shown entering the intervertebral foramen. Fibers arising from the middle cervical ganglion and the pre-communicating ramus are also shown. Notice that these fibers supply the anterior and lateral aspect of the intervertebral disc, the vertebral body, and the anterior longitudinal ligament. These are important notes to remember. Denticulate ligaments separate the dorsal and ventral rootlets. Mixed spinal nerve is located in the IVF. Spinal ganglion is only present in dorsal root. Dorsal ramus are smaller than ventral ramus. The dorsal ramus lies close to facet. Dorsal ramus innervate the deep and ventral ramus innervate the extrinsic muscle. Having understood the neural elements, let's have a look at the cervical nerves. We will obtain answers of the following questions. What are the cervical nerves, how they are formed, and importance from clinical perspective. There are 8 cervical nerves, each existing about the corresponding number vertebra, with exception of the 8th cervical nerve, which lives through the foramen between C7 and T1. The existing cervical nerve lies above the correspondingly numbered pedicle. This differs from the thoracic and lumbar spine. The existing nerve here passes below the correspondingly numbered pedicle. Each mixed spinal nerve divides into ventral and dorsal ramus. Let's first have a look at the ventral ramus. Let's see structures does it innervate and how they are important from clinical perspective. The ventral ramus leaves the mixed spinal nerve. It passes posterior to the vertebral artery, forms cervical and brachial plexuses. They innervate the extrinsic muscles of the cervical spine as a general rule, but there are few exceptions. The C1 ventral ramus innervates the atlanto-occipital joint. The C2 ventral ramus innervates the median and lateral atlanto-axial joint. It also innervates the upper extremities by its participation in the formation of brachial plexus. Let's first have a look at the cervical plexus, how the cervical plexus is formed, and what are the key points that has to be kept in mind, which are important clinically. The cervical plexus is formed by ventral rami of upper 4 cervical nerves. It consists of deep muscular branches which supply the muscles and superficial branches which supply the skin. The deep branches of the cervical plexus innervates the paravertebral muscles, the craniocervical flexors as well as the scalenes, levator scapulae, trapezius and sternocleidomastoid. We will study these muscles in kinesiology presentation. The ventral rami of C1 and C2 spinal nerves supply the atlanto-occipital joint and atlanto-axial facet joints respectively. The superficial cutaneous branches of cervical plexus from the following nerves. Lateral occipital nerve formed by the branches of C2 ventral ramus. It supplies to the skin of the neck and scalp posterior to the ear. Greater auricular nerve formed from the branches of C2 and C3 ventral rami. It supplies to the skin around the ear and mastoid area. The transverse cutaneous nerve formed by the branches of C3 and C4. It supplies to the skin on the lateral and anterior part of the neck. Supraclavicular nerve formed by the branches of C3 and C4 ventral rami. It divides into 3 nerves, medial, intermediate and lateral, and supplies the skin over the sternocleidomastoid, sternoclavicular joint, the upper chest wall, acromion process, upper and posterior part of the shoulder. Recurrent meningeal nerve and its clinical neuroanatomy. Sinovertebral nerves, also known as the recurrent meningeal nerves, are branches from the ventral rami which re-enter the intervertebral foramen and ascend or descend as far as many as 4 vertebral segments within the vertebral canal. Sinovertebral nerve is originated from the ventral rami and receives contributions from gray communicating ramus and sympathetic nerves. There are more than one recurrent meningeal nerve present at each level which supplies posterior aspect of the intervertebral disc, posterior longitudinal ligament, spinal dura mater, posterior vertebral body, oncovertebral joints. The dura-meningeal branches are probably related to the pain referral patterns associated with the upper cervical spine and occipital headache. These are the important notes or the general rules. C7 ventral ramus is the largest, then C8 and C6. C5 is the smallest. Also, the ventral ramus can be damaged during extension injury or during the acceleration portion of a whiplash injury. Let's have a look at the DRGs, the dorsal root ganglions. Let's understand why they are of significant importance from clinical perspective. By definition, the cell bodies of all efferent nerve fibers are located in the dorsal root ganglion, which is also known as the spinal ganglia. All DRGs are located within the IVF with an exception of C1 and C2. The C2 dorsal root ganglion is that the C2 dorsal root ganglion is that it is the only such ganglion normally located outside the dura. The C2 dorsal root ganglion is located posterior and medial to lateral atlantoaxial joint. It contains the cell bodies of sensory fibers innervating the median atlantoaxial joint, the lateral atlantoaxial joint, large part of neck and scalp, posterior occipital region, the coronal suture of the skull. With such an innervation, the irritation of this structure can create suboccipital headaches and other symptoms. With having understood the ventral rami and their distribution, we now move on to the dorsal rami and their distribution. Dorsal rami innervates the deep back muscles with motor innervation to transversus spinalis, erector spinae, splenius capitis, and cervicus muscles. Sensory innervation to the skin of the neck. The dorsal rami of C7, C6, and C8 usually do not have cutaneous. The dorsal ramus of the first cervical nerve is called the suboccipital nerve. Very famous in clinical practice. It exits the spinal cord between the occiput and the posterior arch of C1. It then enters the suboccipital triangle where it supplies the suboccipital muscles. Any changes of the suboccipital any changes to the suboccipital muscles can potentially affect the suboccipital nerve, giving rise to peripheral neuropathy, condition known as the suboccipital neuralgia. T2 spinal nerve branches into dorsal and ventral ramus, posterior and lateral to the atlantoaxial joint. The dorsal ramus loops superiorly around the oblique capitis inferior muscle and then divides into medial, lateral, superior communicating, inferior communicating, and a branch to the oblique capitis inferior. The medial branch of the dorsal ramus of C2 is large and is known as the greater occipital nerve. The medial branch of C2 dorsal ramus is also known as greater occipital nerve. It emerges between the atlas and axis, passes through the atlantoaxial joint capsule, and ascends to innervate the skin over the posterior part of the scalp as far as forward as the vertex of the skull. It is closely related to the posterior aspect of atlantoaxial joint, and as a result, it is susceptible to any changes occurring at this joint. Owing to its large range of motion, the atlantoaxial joint is particularly prone to arthritic changes such as osteophyte growths. Such osteophyte growths may irritate the greater occipital nerve and result in a peripheral neuropathy frequently referred to as greater occipital neuralgia. Additionally, the C1 C2 level is commonly affected by rheumatic arthritis and may become unstable as a result. In this situation, the greater occipital nerve may be a source of occipital pain due to chemical irritation from the rheumatic disease or by the mechanical impingement secondary to the increased range of motion of the upper cervical movement. Also, this nerve receives a communicating branch from the third occipital nerve before piercing the large semispinalis capitis muscles. The greater occipital nerve, accompanied by occipital artery, reaches the scalp by passing through the protective aponeurotic sling. This sling is associated with the inferior and sternocleidomastoids onto the superior nuchal line. The aponeurotic sling actually prevents the greater occipital nerve from being compressed during the contraction of these muscles. After passage through the sling, the greater occipital nerve forces superior into several terminal branches. These branches provide a broad area of sensory innervation extending from the occipital region medially to the region superior to the mastoid process and posterior to the ear laterally. Superiorly, they supply sensory innervation to the scalp from the region of the posterior occiput as far as to the skull's coronal suture. Terminal branches of greater occipital nerve also provide sensory branches to the suboccipital and transverse facial arteries. Disorder of the upper cervical spine, including irritation of the greater occipital nerve or the C2 ganglion, can definitely cause headaches. The superficial segment of the medial branch of C3 dorsal ramus is the third occipital nerve. The superficial medial branch is called the third occipital nerve. It passes posteriorly around the articular pillar of C3, innervates the C2-C3 facet joint, and supplies the skin over the suboccipital region. Close association of the third occipital nerve with C2-C3 facet joint means that any dysfunction of this joint has a potential to irritate the nerve and generate pain within the cutaneous field of distribution. The third occipital nerve has also been implicated in cervicogenic headaches. These three nerves, the greater occipital nerve, the third occipital nerve, the lesser occipital nerve, lie in proximity with each other. All origin from the dorsal ramus. Because they origin from the dorsal ramus, any irritation of the dorsal root ganglion, either of the C1, C2, C3, can cause symptoms. Also note the proximity of the lesser occipital nerve with that of the sternocleidomastoid. The greater occipital nerve has the sensory distribution above the external occipital protuberance as far as to the coronal suture, the vertex. The third occipital nerve has the distribution into the scalp below the external occipital protuberance. The lesser occipital nerve has scalp innervation behind the ear. The lesser occipital nerve lies in close proximity with the sternocleidomastoid. Fate of the spinal nerves C4 to C8. Fate of the spinal nerve C4 to C8. The spinal nerves C4 to C8 exit through their respective intervertebral foramen. It is the C4 through the C3 C4 IVF and C8 through C7 T1 IVF. The Cruvelier plexus is something new in this subject. It is a recent discovery like myodural bridges. We will obtain answers regarding what is the anatomy of this plexus, the interneuronal connections between the dorsal root rami of upper cervical nerves, is the Cruvelier plexus. Many authors have found for C1 a communicating loop joined the medial branches of dorsal ramus of C2 and C3. A communicating loop joining the middle branches of dorsal rami of C3 and C4. And also, there were no communicating branches between the dorsal rami of cervical nerves C5 and C8. These are the summary of the structures supplied by the dorsal and ventral rami. Ventral rami of C1 and C3 supply the craniocervical flexors, Achilles, levator scapulae, trapezius supplies the it supplies the atlanto-occipital joint, atlantoaxial joint, transverse ligament, alar ligament, ectorial membrane, upper cervical durameter, and skin around ear and anterior lateral part of the neck. Dorsal rami of C1, C3 supplies the suboccipital muscles, the posterior neck muscles, skin over the craniocervical spine and occiput, and it also supplies to the ligament nuchae. Neuroanatomy of the cervical intervertebral foramen. Having understood the neural elements, we now move on to understand neuroanatomy of the cervical intervertebral foramen or the gutter of nerve roots, and we will obtain answers of the following questions: where exactly the neural elements lie in the IVF, what is the relationship between the dorsal root ganglion, vertebral artery, ventral root, and the IVF. The IVF is bounded by pedicles superiorly and inferiorly, posteriorly by the facet joint, and anteriorly by the oncovertebral joint and intervertebral disc. Foramen of the transverse process of the vertebral artery lies in the floor of the IVF. The foramen can be divided into three levels. First, upper level, which contains fat, veins, anterior epidural space. Second, mid-level, that contains dorsal and ventral roots. And the lower level, which consists the dorsal root ganglion, ventral root. This is the dissected cadaveric specimen. We can see the vertebral bodies. If you pay attention, we can see the intervertebral disc lying between the vertebral bodies, the facet joint, and the intervertebral foramen. Now, when we divide the IVF into three portions, on the upper part we will find fat, veins, and anterior epidural space. The middle portion we will find the dorsal and ventral roots, while in the lower third portion we will find the dorsal root ganglion, denoted by marked over here by the arrows. This peak over here, denoted by label U, is the oncovertebral joint, and the facet joint is denoted by S. These are the facet joint. Thus, the dorsal root ganglion, it lie in the lower third of the IVF. The dorsal root ganglion and ventral limbus lie in the lower half to the lower third in the intervertebral foramen canal. These arrangements make the dorsal root ganglion and ventral root vulnerable to compression. Dorsal root ganglion may get impinged in the IVF because of the hypertrophy of the oncovertebral joint, because of the prolapse of intervertebral disc, and because of the hypertrophy of the facet joints found in the degenerative processes, degeneration of the cervical spine. Manual therapy techniques for the facet joint release and mobilizations are directed to open up the space in this vertebral foramen in order to release the entrapped dorsal root ganglion and the ventral nerve roots. Pain referral patterns from the facets. This figure illustrates the pain referral pattern from the facet joints. The sympathetic nervous system. We will obtain following answers. What is the innervation in the cervical region? How important it is from the clinical perspective. Sympathetic nervous system is most closely related to the general anatomy of the cervical spine. The cervical sympathetic chain lies anterior to the longus capitis muscle. It is composed of three ganglia, the superior, middle, and inferior. The superior ganglion is the largest and is positioned inferior to the occiput and anterior to the transverse process of C2 and C3. The middle ganglion is not always present, but when it is present, it lies anterior to the transverse process of C6. Usually, the inferior ganglion unites with the first thoracic ganglion to form the cervicothoracic or the stellate ganglion, which is just located inferior to the transverse process of C7. These are the conclusions. Cervical region is jam-packed with the nerves and interconnected plexus. Many of the structures have direct sensory nerve supply. Facets intervertebral disc can be source of headache and pain. Disc also receives innervation from autonomic nervous system. Dorsal root ganglion and vertebral artery are closely situated. We hereby end our presentation. With completion of this presentation, please view the kinesiology presentation to know about the movements and muscles acting on the cervical spine. Thank you for your participation. This is my contact information. Please feel to contact me if you have any doubts or questions regarding the course or the presentation.